here. So this is a slightly more formal rather than panel discussion session, but I'm hoping that we will be able to get a little bit of audience participation. So the title of the session is Challenges and Opportunities in Delivering a Pharmacogenomics Laboratory Service. And the first of two speakers is Ron van Schaik. I've known Ron for a very long time. He's a full professor at the Erasmus Medical School College in Rotterdam in the Netherlands. And he's really a pioneer of this field, especially in offering a clinical service in pharmacogenomics. Now, I think it is fair to say that the Dutch system has adopted pharmacogenomics slightly more rapidly than we have in the UK. There are some important differences between the healthcare system in the Netherlands and in the UK, but I think we can learn an awful lot from what has been achieved so far in the Netherlands. So I'll call on Ron to tell us his experiences in Rotterdam.
Thank you. It's a real honor to be here and to listen to all the talks already this morning. I'm very impressed, and the way that you are addressing this, I think, is absolutely fantastic. So also, I'm learning a lot. When I started pharmacogenetics in 2005, we just started. We didn't think. So this is perhaps even a better approach. So, and I'm also happy to see that there are so many people here in the audience. It's a Friday afternoon already. And one time I had a meeting and I had to present, and there was only one person in the audience the Friday afternoon. It's always a bit embarrassing, but I gave my talk, and the guy listened to the whole talk. And after my talk, I thought I should know more about this person, so I asked, so may I ask who you are, that you're still here for my talk? And he said, I'm the last speaker. So, okay, so yeah. Good, so let's move on. Let's see if this works. Yes, challenges and opportunities in delivering pharmacogenetics laboratory service. Like I said, I'm working at the Department of Clinical Chemistry. I'm head of the department there, and also professor in pharmacogenetics. And let's see what we can do here. So this is the Erasmus MC, the medical center. Let's see if the pointer works. Yeah, okay, so it's the general hospital. Here is the children's hospital, which is attached. We have a specific cardiology, the Daniel de Hoed, oncology center that is located on here. And this is the rest of the hospital, and this is the university tower. Very nicely located. You can see a screenshot from the inside there as well. We have been performing pharmacogenetics since 2005. In 2024, we had 32,000 test requests, which we processed. I will get back to the way we do the testing. We're an International Federation of Clinical Chemistry reference center. Our turnaround time is like 4 or 5 working days. And for specific tests, we have like either 2 times a week or within 24 hours, but I will get back to that. So talking about opportunities and challenges, I thought I should start with the opportunities. And I think the opportunity is quite clear, because we have this clinician that is seeing patients, prescribing them the same drugs, and then, of course, realizing that one of the patients does not do very well on the drugs, has side effects, and the other patient does very well. So this is the clinical problem that we should want to address. And if you look at that, we can go back to that for a large part on the pharmacokinetics. So how is the drug being metabolized? So you can see here on this green line, this is the average patient, and the dosing is in such a way that the blood concentration is in the therapeutic window. But if degradation, if the enzymes in the liver do not work as good as with the average patient, you will have a higher blood concentration and more adverse drug reactions, or higher risk on adverse drug reactions. And if you metabolize much more rapidly, you will have a specific time when you will not have the effective therapy. So addressing this, of course, already mentioned, adverse drug reactions, 5 to 7% of hospitalizations are due to that, and I just saw from Sue that it was even like 16% there. So this is something that we would like to make better, and on the other hand, only 25 to 60% of drugs prove to be effective. So that is why we are going to use pharmacogenetics to improve this. Because if you can upfront predict who will have a slow metabolism, you can dose them lower, the ultra-rapid, a higher dose. There will be more blood concentration in the therapeutic window, and because of that, you expect that there will be less adverse drug reactions and more effective therapy. And that's, of course, what we want to achieve. So if we look at the opportunities and go to the laboratory, this is currently what we are offering. This is the request from Erasmus MC, and there are like 25 enzymes for which we think there is enough evidence to offer pharmacogenetic testing at a diagnostic level. You will recognize the 2C19, which was already discussed, the cytochrome 2D6 in there, the DPYD. But we also decided at a certain moment to make it more easy for the clinicians and to offer like a DNA passport for medication. So that's the first one. And at that time, we still had like a basic passport and a more extensive passport. And of course, we can do all 25 genes in there, but as indicated already earlier, I think that most of the clinicians do not want the full list. They want like a list of genes, and this one is like adapted to that, to medications which there is a high risk that the patient will get that from a GP. So this is a very limited amount of genetic information, but probably is going to be used. Where if you have more specific medication like the DPYD for oncology, that's not in there. Okay, so for having a good laboratory service, you need, of course, a team. So this is part of my team, the technicians that perform the pharmacogenetic testing. But we also have like a molecular biologist for specific questions to be answered, a pharmacist that we have in our department of clinical chemistry to address and to consult, give consultations about dosing. You need research technicians to look into new developments there. And very important also the secretariat. I have 3 secretaries. Perhaps because I need more guidance, I'm not sure, but also because we get a lot of requests and questions from GPs, from specialists, but also from patients about the pharmacogenetic testing. I think that part of the success of Erasmus MC in there is that we're very accessible by either phone, email, or website to have information on pharmacogenetic testing. So is pharmacogenetic testing, how is the awareness of pharmacogenetic testing? We started in 2005, and then we had like 25 patients for which we could do pharmacogenetic testing, and I was very proud of that. And in the year after that, we already had 30, so I thought like, we have a good increase there. But during the years, and you can see that there's a large increase in the pharmacogenetic testing, and like I said, in 2024, we had like 32,000 test requests, which represents approximately 20 to 25,000 patients. So this proves to me that there is more awareness and that clinicians know where they can ask pharmacogenetic testing. And when we did a survey, we also found that as a feedback that clinicians reported that I could help actually some patients that had severe side effects, and now I can explain why these side effects occur. And if you look at the distribution of the tests, you can see that the 2C19 is currently the most requested test, like 30% of our test requests is 2C19. And then we have like 12% for the 2D6, and for the DPYD, which is for capecitabine, like 5%. And this is mainly in cardiology, neurology, and psychiatry. 2D6 is mostly psychiatry request, and the DPYD in the UGT1A1 is in the oncology section. And I think that depending a little bit on the hospital that you're working, you can see shifts in which tests are most frequently requested for. So choices to make as a laboratory, I listed some of them here. The genotyping platform, are you going to use CE-IVD or research use only? What's the turnaround time that you're going to do? Are you going to do individual testing or multiplex testing? Are you going to use arrays or next-gen sequencing? And also, how many genes are you offering and how many variants per gene? So we offer 15 variants for 2D6. There are labs that offer 6 variants, others use like 10 variants. Are you going to offer blood, saliva, or cheek swab? John already mentioned that as well. The turnaround time, is it 1 day, 1 week, or 1 month? 1 month is, of course, from a laboratory perspective, more cheap. But then again, we realize that patients and clinicians may not want to wait 1 month. And I think that 1 is better appropriate, or perhaps even like 1 day. The report, are you just going to report the outcome of the genetic test? Somebody is a poor metabolizer or an intermediate metabolizer. Or are you going to give dosing advice? If the sample is being sent in because a patient is on SSRIs, why should you not have dosing advice for SSRIs there? Are you presenting like a DNA passport, so like a card, whatever, including all the genetic information, or are you going to just give the lab results? And are you going to take requests from the medical specialists and the GPs, or should you also consider direct-to-consumer testing? And then information, website, phone, emails, folder. So these are all aspects that as a laboratory you have to think about. And I have here in red the choices that we have made like I said, turnaround time should be 1 week. For a DNA passport, we went for 6 genes. And we're not taking samples for direct-to-consumer testing. We have focused ourselves on the medical specialist. Already mentioned the saliva of the cheek swab kits. We introduced that in 2016, and I think there was a great success. Currently, like 25 to 30% of our test requests are by this cheek swab kit. The physician can, on the portal, on the website, ask, I want to have a DNA test for my patient. Please send this kit to the patient. We send it to the patient, they take the cheek swab test, and they send it back. We have like background information on pharmacogenetics. We have a manual how to use the cheek swabs and an envelope to return it. And this has been shown quite successful because the patient does not need to have blood drawn, does not need to go to a site to have the blood drawn. And in that way, I think that we have certainly established a means for patients to get more easy access to pharmacogenetic information. Something about the reporting, which I said, do you provide just the outcome of the test? You can see here, so it's in Dutch, but you can see 2D6 genotype, for instance. You should mention which variant alleles you have investigated. Then you say which variant you did find. So this is star 4, 2 inactive alleles. It's a slow metabolizer. And then here it says something like, okay, the activity of 2D6 is low. Please consult your pharmacist for specific medication if any dose adjustment is needed or not. In case that the physician has indicated, okay, there are side effects of fluoxetine, nortriptyline, risperidone, then the report looks different. So then we take into account the genotype of the patient, and for instance, for the nortriptyline, I highlighted that one, we will say in the report, nortriptyline is being degraded by 2D6, the genotype will fit with high blood levels and side effects, and consider a 40% dosing of the normal dose. And then also indicated for a number of other drugs, there are adjusted dosing available for this genotype. Please consult your pharmacist. Because you have to realize that the dosing advice that we're giving here may not be valid anymore in 10 years when there is new knowledge available. But I think it's important that, that you answer a question. So this is like part of the Swiss guidelines, which were published like 20 years ago. You should answer a specific question there. So now we come to the challenges. I think one of the challenges, or an important challenge, is the healthcare provider. Because if we offer this test as a laboratory, will he indeed order the test? And I have 3 examples to talk about. Like, one is in psychiatry. So when the idea of like antidepressants being metabolized mainly by 2D6 became apparent, we looked in our hospital, and in our hospital at the time, there was a lot of imipramine being prescribed. And you have to realize these are all patients that did not respond to SSRIs with the GP. So imipramine being metabolized to C19 to desipramine, both are biologically active. The 2D6 is the inactivating enzyme. And these patients are being dosed based on the blood concentration. You have to wait 1 week before their steady state. You get the blood sample, you measure the imipramine concentration, then you have to wait, then you have to see if you have to adjust the dose, and in 50% of the patient, the dose needed to be adjusted. You have to wait another week, you take another sample, perhaps you have to wait another week and adjust, and so forth. So usually 4 to 6 weeks before you have the proper dose. And we decided to look for what is the end dose by TDM, by kind of trial and error, and compare that with the number of active 2D6 alleles. And we did find this very nice linear correlation. So if you're a poor metabolizer, you do not have the 2D6 activity here, you cut at approximately 100 milligrams per day. If you have 2 active alleles, then you're like higher. And it's like 30% of the standard dose that you actually need for a poor metabolizer. So we thought that with these data, we could also convince our psychiatrists to use the pharmacogenetics, and especially when we also showed, or when it was shown, that if you use conventional therapy and you look at responders by depression rating after 8 weeks, you could see that if you have the conventional method, 23 to 30% of patients are actually responding. But if you use DNA information, the response rate is significantly higher, between 44 and 50%. So if you do the calculation, that's what we did in our hospital. And to say like, okay, based on these data, you could show that if we would use this to treat our patients, we use DNA information, then we would save, as our hospital, €400,000 per year on patients being in the hospital. And I thought that was a good argument. but the head of the psychiatry at the time said, like, but if I use this, then I have empty beds in my department. And my insurance company does not allow me to take more patients in, so we're not going to use this in this way. So in that way, it was a little bit slowed down. Now, happily enough, that changed. Also, the psychiatry, the Dutch Society for Psychiatry now included guidelines for pharmacogenetics. So you can see, for instance, if you're 2D6 poor metabolizer, amitriptyline 70% of the standard dose, clomipramine 50% of the standard dose for intermediate for poor metabolizer, intermediate 70%, ultra rapid like 150%. So now finally also the psychiatrists in their guidelines have dosing recommendations. And to give you a little bit of flavor on how long that took, we started the pharmacogenetic service around 2000, actually as a diagnostic service in 2005. The Royal Dutch Pharmacy Association had the Dutch Pharmacogenetic Working Group, and they calculated the dosage that you could give evidence-based based on the 2D6 genotype. These were available in 2005. So the good thing is when the Dutch psychiatry guidelines came out, that the dosing advices were exactly the same as from the Royal Dutch Pharmacy Association. But there's 15 years in between. It took 15 years before this reached the clinical guidelines of this specific group. So sometimes it can take a long time. The second one I would like to talk about is the cardiology. Clopidogrel, as I already indicated, is a prodrug, needs to be activated by 2C19. 2% of the Caucasian population and like 11 to 14% of the Asian population does not have the full function of the 2C19. And you can determine that by the genotyping. It has been very nicely shown that if you're a carrier of an inactive 2C19 allele, this is the risk of 1. As you can see, all studies show a significantly increased risk on death, myocardial infarction, and stroke, so not the least of endpoints, I would say. And these were all published in 2009 and published in JAMA, New England Journal, and The Lancet, so also very high-ranking journals. So it would be easy. Test for 2C19. If you do not find any variant, you just prescribe clopidogrel. And if you do find variants, you go to the more expensive alternatives like prasugrel or ticagrelor. And just to see the difference, 1 year clopidogrel is 15 euros, 1 year of ticagrelor is 800 euros. So it's a big difference. And we were very keen to see if that would go into practice. And the European Medicines Agency has added also information there in 2011 saying like, okay, they updated the SPC and they said that there's a variability in the response to clopidogrel due to either genetic variation of the 2C19 enzyme. And that is in section 4.4, precautions. It says in patients who are 2C19 poor metabolizers, clopidogrel at recommended doses forms less of the active metabolite and has smaller effect on platelet function. Very clear warning in there. And I was quite surprised when in 2015 the European Society of Guidelines came out. I was very interested to see what they would say about 2C19 testing, but they stated here, at present genetic testing cannot be recommended in routine clinical practice due to insufficient prospective data. So I showed you the results. Yes, there were retrospective data, but apparently EMA was convinced, FDA was convinced as well, but then still the clinical group says, well, we do not really want to recommend the 2C19 testing there. And that was a little bit of a problem, because then also in the Netherlands, you can either follow the EMA advice and test for 2C19 before prescribing clopidogrel, or you can avoid clopidogrel and prescribe the alternative drug, ticagrelor. Erasmus did that. I said, but it's more expensive. And they said, yeah, well, the test I have to pay from my department budget, and the drug goes from the hospital budget. So, you know, it's so sometimes all kind of other issues are there. Or follow the cardiology guidelines and do no 2C19 testing. Well, especially regarding this one, there was a very interesting paper which I think made a change in the behavior of the cardiologist. It's a Dutch paper published in the New England Journal. And they compared the standard ticagrelor against clopidogrel when 2C19 genotype allows. And if there was a variant, then you go to ticagrelor, but you still stay in this particular group. At first, they were very concerned whether the antithrombotic effect would be the same in these two groups. And they indeed found that this clopidogrel with 2C19 was non-inferior to the standard ticagrelor. But the point with ticagrelor is that it's very good, a very good drug. So you have primary bleeding outcome that you have to be worried about. And then it was shown that the standard ticagrelor has a higher risk of bleeding. So in fact, now you can see that the clopidogrel together with the 2C19 is safer than using the standard ticagrelor, and it's also much cheaper. And after this, we noticed, I'm not sure if this is the reason, but after this, we found that there was a high increase in 2C19 requests. And also now in the 2019 guidelines of the European Society of Cardiologists, it is now to refer to, okay, be aware that 2C19 needs to be activated, that there is loss of function variance leading to lack of efficacy in some patients. Be aware, it still does not say that you have to test. It just say, if you know the genotype, there's a higher risk. But if you know that, then you may want to have that risk taken away and do the 2C19 test directly. So at my lab, we then realized we did all the testing like once a week for economical reasons. We realized that we should offer this test result more quickly. So we're doing now the 2C19 testing every day. So that means that within one day you will have the result there. And I thought that the cardiologists and neurologists would be very happy with this result, but they were now so enthusiastic that they want the result in 2 hours. So I tried to convince them, like for 10 years you didn't care about this, and but... So you see here one of the 2 point-of-care devices that are currently on the market, and one of these devices is now at the cardiology department where they can do the 2C19 testing near the patient themselves. And like I said, this new guideline for 2C19 cardiology was in 2019. So with the cardiologists, it took only 10 years before it was in some guidelines. So we're improving. Third one is oncology, capecitabine and 5-FU. Capecitabine, a widely used anti-cancer drug. 10 to 30% of the people develop severe grade 3 toxicity, and 1% of the patients actually die of the therapy. So you can see here capecitabine is being converted. The DPD enzyme is important here. It creates an inactive metabolite, and 1.5% goes to the active metabolites. But there are people that do have DPD deficiency, and because of that, all of the capecitabine goes to the active metabolites, and that creates a toxicity. And DPD deficiency occurs in 3 to 5% of the population. There are several alleles. This is one of the most important ones, but there are 4 alleles that have now been seen that they have an increased risk on toxicity, and these 4 alleles are depicted here. These 4 SNPs are depicted here. And we did a prospective study in which we compared the toxicity, the risk of toxicity in a historical cohort, which is shown here. This is the reference being 1. And then have a dose reduction, do upfront genotyping, and have a dose reduction of 50% for these 2 variants, and 75% of the dose, or 25% dose reduction for the other variants. And we've shown in this Lancet paper that indeed you did see a decrease in the toxicity here, especially for this one, is very clear, and also for this particular SNP. Very importantly, we also showed that the 5-FU levels were comparable between wild-type full-dose patients and variant carriers with a reduced dose. So the dose reduction that we applied did not lead to undertreatment. And in 2024, we also published that the overall survival and disease-free survival were comparable if you look at these particular genotypes. So the effectivity of the treatment did not suffer from having a lower dose in there. We also showed that if you use DPYD-guided therapy, it's cost-saving. So it's not only cost-effective, it's even cheaper to do the genotyping in that way. And I think that is also very important. But the most important part of this is that this DPD genotyping got accepted by the oncologists very rapidly, within 2-3 years, even before the study results were there. And the reason was that we have included like 12 different hospitals to participate in this study. That means that all the oncologists were already informed and trained in having a pharmacogenetic test in there and see how they could manage with the results. So I think this is one of the reasons why this was very, very rapidly accepted. So this is also a lesson for us. Now we've talked about all these medical specialists, and already mentioned here was the GPs. So I was very curious to see how many GPs were offering pharmacogenetic testing. So we looked at the data we had in 2021. Then we had 8,500 patients that were sent in, representing 23,000 pharmacogenetic tests. And it appeared that approximately 14% of them, 1,206 request forms, were from GPs, representing like 6,000 pharmacogenetic test requests, 27% of all. And I was quite surprised that so many GPs apparently wanted to know about the pharmacogenetics. And we did a survey there, also looking for which were the drug groups for which most of the pharmacogenetics was requested. And you can see antidepressants, 50% of the requests. then the antihypertensive 26%, and the anticoagulants, then also opioids, statins, beta blockers, PPI, antipsychotics. So quite a range, but antidepressants really stands out there. And if you go then to the individual drugs, then mainly clopidogrel actually is like 23% of the cases pharmacogenetics was requested for that by GPs. So I was quite surprised there as well. And then you have a mix of like antidepressants, beta blockers, pain medications, and others. But apparently clopidogrel is also very much in focus with the GPs if it's about pharmacogenetic testing. We also looked, why did you ask for this test? Then 79% was like for side effects, 27% for non-response, 30% prior to therapy. And this is very much in line with the guidelines that we have available for primary care. Because there we say, if you may have listened to a lecture of Ron van Schaik and you got very enthusiastic about pharmacogenetics, don't use it directly in your GP practice. You know, you're perfectly fine prescribing your first choice drug for an antidepressant. But then if you see side effects or the drug doesn't work, then consider if you should do pharmacogenetic testing. And that's exactly what is also reflected here. We also set out a survey to see what are the barriers that GPs are encountering when using pharmacogenetic testing. And you can see that lack of knowledge is an important factor there. Unclear when to test, lack of experience, unclear which test to request, unclear how to request the test, unclear how to interpret the results are like among the top 5 of the reasons for the barriers. So I think that we should really focus on education there as well. We also asked for what are the sources, where did you get your pharmacogenetic information? Like 34% went to the pharmacist for have additional information, then followed by publication in the Dutch College of General Practitioners, 21%, and the website pharmacogenetics.nl, which is 70% of the people refer to. And in fact, this is a website that I set up at the time that we were offering pharmacogenetic testing because we got many, many questions. So I tried to have this like as an independent national website, having the different labs registered there that perform pharmacogenetic testing, which is in the Netherlands like 16 different laboratories at that time. We have also information for patients, we have news, we have background information about pharmacogenetics, but this one is the most used, which is the tables. And the tables you can see here is called like the clinical relevant enzymes, and here it's on alphabetical order, all the drugs, and the list goes longer, and it shows in the first 2 columns the clinical relevant enzymes. So for instance, for amitriptyline, 2D6 and 2C19 are the important enzymes. So if you have side effects, these are the two genes that you have to ask to be tested. And this one is based on the enzyme. So if you're like, for instance, the 2C9, you can see that these are the drugs that have been metabolized by 2C9. And for this one particularly, there is even a dosing advice available. So if it's in red, then the Royal Dutch Pharmacy Association has a dosing advice available, which is different from the general dosing. And this has been used quite a lot. And if you're interested in that, I have like several of the cards also here. I didn't realize that we have such a big audience, and also I have only hand luggage, so I couldn't carry more. But if you're interested, here are some of the examples listed. And then, of course, we should not forget about the patient, because also patient empowerment is important. So that's why we indeed started an app, was already discussed earlier. So if we get a request for pharmacogenetics, the GP receives a code which he can give to the patient with this particular information on like the different enzymes and the activity there, normal, higher activity or lower activity. It will also explain the patient genotype in relation, like if you're star 17, it will say you have a faster metabolism of the 2C19. But you can also have the list of the different drugs here, stating like, okay, your metabolism for acetylcoumarol is different, for amitriptyline is different, and if you click on either of these ones, you get more explanation how your genotype is related with the drug there. We introduced this in 2021, so I was a little bit afraid that I would have a lot of angry GPs calling me like, okay, now my patient is telling me about pharmacogenetics, which is in fact a good point, of course. But we did not see that, and I think that is patient empowerment, and it makes sure that you have shared decision making. And it saves the clinician time to explain all about the pharmacogenetics because the patient already has this information. If you would like to try this app is called Pharmacogenetic Profile, so it's in Dutch, but you can change the language of the app to English. And I hope this code still works. I asked for that several times ago. If you have this code and you have like the year of birth to fill this in, hopefully you should be able to also have a look at this app and see what kind of information is in there. Okay, then we have also a challenge on the laboratory part still to deal with. Like I said, in the Netherlands, we have 16 ISO-accredited laboratories, ISO 15189, meaning that we can have a diagnostic service. These are all labs that perform pharmacogenetic testing. These are not the clinical genetic centers. Like from the 16, I think there are like 14 which are clinical chemistry laboratories. We have one clinical genetics center and we have one pharmacology center that is offering the testing. But still the labs differ a little bit in the price per test, the number of SNPs they do, number of genes they offer, the turnaround time, the reporting plus or minus advice, the material which is used, yes or no DNA passport, and also like do they use CE-IVD testing or do they have research use only testing which they have validated to be performed as a lab developed test. So of course having this around, you would like that it's more or less centralized, so or at least harmonized. So I started this network clinical, it says like network clinical pharmacogenetics in the Netherlands, and I organize like once a year a meeting in which hopefully all these labs participate to see what are the differences, and in that way try to harmonize as much as possible. One example, of course, suppose you have a patient with side effects of nortriptyline. If you go to this particular lab and they test for star 2, 3, 4, 5, 6 and the duplication, you may find that this patient has 2 active alleles and is a normal metabolizer. However, if another lab, like our lab, is testing on more variant alleles, you may find that this patient is actually a star 17 intermediate metabolizer. Because you have to realize that star 1 is a kind of default value. We did not find the variants we were looking for, but if you look for more variants, you may still find there's a difference. So as a national initiative, and being all labs that have started this, we try to harmonize as much as possible, because in the end report, it will just state your 2D6 normal metabolizer or intermediate. But you have to know what was tested. So this is one way to harmonize that. We also started there with Association of Molecular Pathology, an activity to have like recommendations for clinical testing, for instance for 2D6, but there are several other enzymes as well. And we said, okay, we will define tier 1 and tier 2 alleles. So tier 1 alleles is the minimal set for clinical testing, and that's based on well-characterized effect on enzyme function, a minor allele frequency in more than 1% in a population, so not just the Caucasian population, and having publicly available reference materials. So for the cytochrome 2D6, we came out as these 15 variants that we think that you should test if you are offering 2D6 genotyping as a lab. So I did a survey among these 16 labs that are offering pharmacogenetic testing, and then I have highlighted the ones that are indeed in this tier 1 guideline. So these are in red. You can see most of the labs do testing for a lot of the variants, but for instance, the star 17 and the star 29, not all labs test for that. So one of my incentives, one of my initiatives is to make sure that also these labs come up to speed with what is required for 2D6 genotyping. So this is trying to harmonize in the country. And then the last part, we're coming to the dosing and advice, the role of the pharmacist or clinical pharmacologist. The FDA has a very nice list of biogenomic markers. For more than 300 drugs, there is now pharmacogenetic and pharmacogenomic information available in the drug label. And that table looks more or less like this. You can, for instance, look at amitriptyline. Therapeutic area is psychiatry. The biomarker is 2D6. And the labeling section is here precautions. But it can also be in indications and usage, or as a boxed warning, or in clinical pharmacology. And you see a little bit what is the problem. This pharmacogenetic information can be anywhere in the drug label. And when I was in Washington, that's quite some time ago already, and when the FDA was explaining this and to see in which section pharmacogenetic information would be, somebody got up and said, well, I'm a GP, you do not really think I have time to read all the drug labels. And I thought it was a good point, but I can still see the other guy standing up on the other side of the room and said, I'm a lawyer, I can tell you we do have time to read drug labels. So this is a problem, and the solution is quite simple. That's called the pharmacist, because the pharmacist knows what is in the drug label and can also advise on how the drug dosage should be adjusted. So I think this is a very nice collaboration between the specialist GPs and the pharmacy. So that means that we have to train pharmacists. So this is in 2017. I'm here with my colleague from Leiden University Medical Center. We had a little classroom of 1,500 pharmacists who we give a lecture on pharmacogenetics for a whole day, hoping that this will catch on. And we do repeat this kind of events. We have like e-learnings, we have publications. So we have every time we come back to this, having all this information available for pharmacists so that they can indeed give advice to the GP or to the specialist there as well. Because in 2000, this was the joke in the New Yorker, can you go with your pharmacogenetic information or your DNA information to your local pharmacist? And in the Netherlands, since 2005 already, this is possible. Because we had this Dutch pharmacogenetic working group which has evidence-based dosing guidelines. And this is accessible for every pharmacist in the country. It's a national initiative. So 15 people which are in this group. I'm one of them, a very mixed group there. And we go through all the literature in a very systematic way, rating the evidence and rating the clinical effect. And if that is enough evidence and the clinical effect is sufficient, we'll calculate what should be the appropriate dose. And like I explained, it's for every pharmacist in the country. So I thought at that time I should check that for you. So I went to my own pharmacy at that time, small village in the center of the Netherlands. I went inside and I said, okay, I'm depressed. I come from my imiprimin, but I'm a 2D6 poor metabolizer for educational purposes. So the guy went into his computer, and then you can see the screenshot here. It says from the Royal Dutch Pharmacy Knowledge Bank, it says 2D6 poor metabolizer imiprimin, and somewhere here it will state that I need only 30% of the standard dose. Every pharmacist has this information. I can go to any town, any village, any city. I have the information, and I get the same advice up north in the country, in the middle or in south, which is, I think, also good. That's why it's important that it's a national initiative. The only thing is that I had to tell him it was in his computer. So I said, what? I said, you can look that up in your computer. So he learned something from me as well there. Okay, but he had it. And then again, like Sue already indicated, he has information on all these drugs. You can see these are the actionable ones, 60 drugs, 18 genes. And for all these drugs, you can see that these are the relevant enzymes in column 1 and 2. And if it's in red, then we have an adjusted dose based on the genotype. So looking at all this, like this is like all these genes, should you now have like this information up front? Should you already go for like a DNA passport or not? Should we test per gene as if we have been taught always, only ask for the test which is relevant for your patient at this moment? Or should we be more economical and go for panel testing like preemptive? And I really do not know the answer yet, but this is something that is an ongoing discussion. And especially since the PREPARE study came out in 2023, showing in 7 European countries and 8,000 patients that you had 30% less adverse drug reactions when using a 12-gene DNA passport for medication. So that means that I wondered, like, okay, if I have indeed this DNA passport, can I indeed go to my local pharmacist? So this is not my local pharmacist, this is Erasmus MC, because I thought I should also check if my own pharmacy knows what to do with the DNA passport. So I went inside, I said, okay, this is my DNA passport for medication, I'm depressed, you know, I come from my imiprimin. She immediately went into her computer, and you can see here the screenshot saying, like, imiprimin, poor metabolizer, lower the dose to 30% of normal. And I told her, I gave her a compliment, because I think it's very good, because your colleague last time, I had to tell it was in his computer, and then she said, but I attended your class last week. And I thought this is exactly the point that we have to do. Sufficient education that people know what's going on. Almost there. This is summarizing.
Yeah, okay,
yes.
Okay. 2 minutes.
So challenges and opportunities of delivering pharmacogenomic laboratory service. Opportunities, there's a medical need, diagnostic tools are available, and evidence-based dosing guidelines are also available. The challenges we still have, to have the pharmacogenetic test indeed be ordered by clinicians, or to have it into guidelines, does not need to be the same. Education of healthcare providers, I think, very important, and harmonization between laboratories is also very important. And you may realize that one important part is missing here, and that's about reimbursement. And the point is, in Netherlands, it's reimbursed, so that's not an issue for us. But I think in other countries that could still be an issue that as a challenge, that could be covered. So hopefully this clinician, when I come across him at the coffee machine, will now immediately say, I should order a pharmacogenomic test, being aware now that it's around. And if he does not know enough about that, then I invite him, and also you, if you want to know more about pharmacogenetics, at the European Society of Pharmacogenomics and Personalized Therapy Congress in Rotterdam in November 5 to 8. Thank you very much for your attention.
Okay, thanks very much, Ron. Before you go, we have time probably for just one question from the audience. I promised some audience participation, so hands up if anyone wants to ask Ron a specific question on what he has told us.
I'm right on the opposite side.
Oh,
Ah, Mark. Good to see you.
Just thought I might be able to help with the question that you had around whether doing specific genetic testing or panel
I
testing.
have to talk a little bit louder.
Can you hear me now?
Now
Yeah.
I
A bit
can
better?
hear you. Yes. Yeah.
Yeah, I just thought it seems like from the conversations that we had this morning around patient empowerment and giving people access, and also the data from the PREPARE study around 30% reduction in pharmacogenetic testing before the drugs being prescribed. It seems like it would be quite clear to answer the question on whether we do reactive testing or preemptive testing. It seems that preemptive seems to be a little bit more of a benefit that we would be getting, and then potentially looking up to whole genome sequencing so that we have a full data set that we can keep coming back to and reanalyzing. So what would be the difficulty of moving to panel testing or whole genome sequencing first?
Okay, so that's quite a question that you put there. So if you go for whole genome sequencing, okay, it's more costly, but you have a lot of information. I'm always a little bit worried there that if you find variants which is not described in literature, what is the clinical consequence? And I know that in Clinical Genetics Center, you just report we found a variant of unknown significance, but then I think then you have the healthcare provider to deal with that problem. So I think that we should just focus, for me at least, just focus on the variants that I know what is the effect and how we can have an adjusted dose. So that's for the whole genome sequencing, but I think that we will go absolutely in that direction. Your other question is like the preemptive testing. Shouldn't everybody have a DNA passport? Should it be at birth? Should it be when you turn 18? Or the thing I think is the first time you get a drug prescribed for which pharmacogenetic information is important, then you go for pharmacogenetic testing. But while you do that, then you may just as well define as a DNA passport. And if that's 6 genes, 12 genes, or 30 genes, we still have to discuss. But I got a lot of feedback, like last week when I was also teaching for GPs. They said, I don't want 30 genes. I want a limited amount of genes for which is relevant for the drugs I'm prescribing in my GP practice. So there is also, whereas as a pharmacist you may say, okay, but I just want all the genetic information to be able to prescribe the drug for any drug during the lifetime of a patient. Because that's one point I forgot to say. If I go back to my pharmacy 5 years later for my metoprolol, it will give an automatic warning that my metoprolol should be adjusted. If you register now my genotype, there will be, for all the drugs in the future that I'm being prescribed, there will be an automatic warning in there as well. So the preemptive test, I hope that at a certain moment, and that's really my belief, that we shouldn't talk too much about cost anymore. Sorry, Sue. But I think at a certain moment, I think it's not ethical anymore not to use the information that we currently have available. We're prescribing drugs to patients, thereby exposing them to a certain risk, and we have the knowledge and the tools to reduce that risk. And of course, that should be within specific financial parts there, but I think that we should really work to get that available for patients. Thank you for your question.
okay. Thank you very much, Ron. That's a very good answer, a very comprehensive answer. And Ron is here for the rest of the day. In fact, he's spending the whole weekend in the lovely city of Newcastle. So you can speak to him later. So our final speaker before lunch this morning, or this afternoon, is Dr. Emma Howard. Now, Emma is a graduate, a primary degree graduate from Liverpool, who then went to Manchester to do her PhD. Now, after a couple of years as a postdoc, she joined the NHS in 2001, and she became head of the Northwest Genomic Laboratory Hub in 2020, and essentially has very appropriately, given her academic background, has merged the Liverpool and Manchester labs. So she's going to talk to us about her recent activities in the area of implementation.
Thanks, Phil. Thank you. And thanks again for asking me to speak today, and a hard act to follow with Ron, with their setup in the Netherlands. So, you know, bear with me, we're a little bit behind the curve. I suppose the talk that I'm going to give is broken into two parts. The first one, I'm going to detail some of the standard of care NHS diagnostic delivery from a couple of our assays and go into a bit of a deep dive there, because I really want to demonstrate that sometimes people say to me, the lab is the easy bit, it's everything else. And actually, from where we sit in the lab, it's not the easy bit. And even though it's a non-complex assay for us, pharmacogenomics, it's still quite involved. And I want to articulate that to you today. The second part, I want to look forward. So I want to look, like Sue said, how do we scale? How do we get to the heights? How do we do what Ron's doing? How do we do it on maybe a preemptive setting? And how do we get to that from a laboratory perspective? So it's very much focused on diagnostic, standard of care delivery for pharmacogenomics. So just to set the scene, and introduced it very well in that I am the scientific director over the Northwest Genomic Laboratory Hub, 7 hubs in England. We're in the Northwest. We've got 2 sites. I merged those. We part of that merger in 2019. The largest site's at St Mary's in Manchester, and we rent space in the Liverpool site. So all the staff are employed under Manchester Foundation Trust, who is the lead provider. And just to sort of understand how the work is proportioned, the St Mary's site is the high throughput site where the majority, if not all, of the NGS is now done, and the array service. And the Liverpool site takes on sort of cytogenetics, more like where there's no batching required, hem-onc, RD, core RD services in molecular, but also their niche area is pharmacogenomic delivery. So all of the standard of care NHS is done out of the Liverpool site, and we serve a population of about 13%. Sue mentioned the National Test Directory, and here it is in all its glory. This is the predominant part on the table at the top is the Cancer Test Directory, and that's where the DPYD the hotspot sits. And you can see it's detailed for a number of tumour types. And then we've also got these other 2 that Sue mentioned as well. One is for mavacamten, so it's for obstructive hypertrophic cardiomyopathy, and that's CYP2C19. That went on the test directory in January 25. And then we've got the mitochondrial one. I'm just going to focus in today on our service delivery around DPYD and CYP2C19. So, just starting with DPYD. When we set this up, we were probably the first GLH in the country to do so, and we did it in a pilot phase before it was commissioned on the test directory. And we really did develop it from scratch. It was very much, how can we do this? How can we work with our local cancer hospitals to make this work? And not just about the testing, but it's actually getting the samples to the laboratory in a timely way. How do we put those logistics in right from the start and build that infrastructure? And we started with the Christie, and we had really good engagement. It was actually Bill's wife at the time, Fiona, that helped with this. Yes. I should say she was our cancer lead at the time. So thank you. And yeah, so we worked with the Christie to do that. And we developed an SOP around that pathway. And it worked really well. And then we rolled it out to get to Clatterbridge as well. So for those that don't know, and we spoke about this today, DPYD testing is a reactive test, and the NICE guidance back in 2020, I think it was now, recommended that it was tested up front for any prescription with fluoropyrimidine chemotherapies, such as 5-FU. About 12 to 30% of patients experience severe toxicity, and this is because there's a DPD enzyme deficiency that can lead to that. And, you know, heterozygotes in there, so if you have one variant, then requires a reduced dose, and if you have 2, if you're homozygous or a compound het, then you could have severe neutropenia and would need a different chemotherapy, or it can actually result in death. There is an antidote, it's very expensive, so you know there's a real driver here this is a very reasonably priced test to make sure that those adverse events don't happen. Just to give you an idea of what we currently are receiving and delivering, we do about 425 currently of those DPYD tests a month. We deliver it by LAMP technology. This is a loop-mediated isothermal amplification. The benefit of this technology and why we chose it, it doesn't require DNA extraction. It does require a blood test. So that blood comes in and we do a lysis prep of it. And that means that we don't have problems with storage. So we don't store those blood samples. We keep the blood sample until the LAMP test's done. Once we know it's we've got the test result and the report goes out, we routinely dispose of that blood. So we've not got this long-term storage problem, because I don't know if you know, we've got to keep samples for 30 years. The FLC path guidelines very clear. If you extract DNA, you keep it for 30 years. It does lead to long-term storage archive problems in a laboratory. It's fast cycling, that's why we chose LAMP. It's highly sensitive. And we work to a 5-day turnaround time, but we averagely turn around in 1.3 to 1.8 calendar days. We currently assay for these 4 variants, which are just the common ones. We are working on new assay designs to add new variants to it at the moment, and Vicky, who's my deputy, is working with different companies to do that at the moment. Just to detail the just to give you an idea of how long it takes in the laboratory, 4 hours probably start to finish. Like I say, blood lysis, no need for DNA extraction, a couple of hours, robotic setup, quite hands-off, another bit of robotic setup, onto the machine, which is the Quant Studio, off the machine after 15 minutes, quite quick. This is what the results look like. So we've got it gives you a melt curve plot. So you can see the normal allele has a different melt curve, different temperature that you see the peak at. Likewise for the variant allele, that's homozygous. And then we've got a heterozygote at the end, just to show that that's the sort of results that the lab team get. We've automated that as much as possible. So what I'm trying to demonstrate is, we're up against time here. We've got to make that process as slick as possible in the laboratory. So when that genotype comes off that machine, it's populated in this way. It's an automatic pull. There's 4 patients on here, 4 different variants. When you see the check there, that's a normal control. And then you've got the 4 positive controls in there as well, automatically pulled. We've also gone to batch reporting. So that means for normal genotypes, they do mail merge and they're out. And we've gone to single signature reports as well to speed up that time. All reports are sent to a centralised email address. And that was key for when we set the pathway up. We don't want those results going back into individual referrers to sit in their email box. They need to be acted on quickly. So we work with the biochemistry team in both Clatterbridge and the Christie, and it goes to a centralised email address. We also, if there's a positive, we phone that through. So it goes out by email, the admin team get on the phone to alert them that there's a positive that needs acting on. Some of these patients are inpatients, and the results are acted on very promptly. So before I flick over, that's an example of report at the moment, and I will come to this. We're still on PDF reporting, even though we're on single signature. It's still cumbersome, and we need to move away from that if we need to scale. So turning now to CYP2C19, like I said, we're currently commissioned to do that centrally, and that was from January 2025. But we actually did a pilot with Bristol Myers Squibb for a year before it went on the National Test Directory. We delivered that with Dundee, so we were the only provider in England at the time. We're now delivering for half the country for the mavacamten drug, which is a cardiac drug. And then on top of that, we layered that CYP2C19 testing for the clopidogrel pilot, working with the Network of Excellence. And, that required 3 different trusts, which are Doncaster, St George's and Royal Devon, and Salford with point of care. So there was comparison data there. And, I'm not going to go into too much detail here, but for that, we've tested combined with the mavacamten, over 1,016 patients so far. We deliver this also by LAMP, and the standard turnaround time is 5 calendar days. And you're probably aware that obviously clopidogrel is a blood thinning drug, and for patients with strokes, it can be less effective depending on the genotype. Example of a mavacamten report, again, it's a PDF, and you can see we test for the 3 common variants there. So look, just homing in on the trial, on the pilot that we worked with the Network of Excellence. The number of samples taken so far were 468, although we only tested 424. It's a 9% mismatch, and some of that's because, they decided not to be tested or it didn't come to the lab. I will say that there's been, I think when there's a pilot, the difference between the DPYD when we set that up in a pilot, because they knew that it was going to be commissioned, was taken far more seriously in terms of the logistics. So the pathways from the pilot sites in the clopidogrel I don't think have been firmed up in that getting the sample to the lab is really important, because the time lag is not within the laboratory. A lot of it is when you look at the audit data, it's receiving the sample. So, you know, it's that engagement up front that's really important. Just to compare the results, you can see that DPYD and CYP2C19 from the laboratory, and year on year we've increased the number of tests for DPYD. And you can see that on the far side there, you've got the compound hets or the homozygotes, and they're the people that would have been severely affected if they'd been given 5FU up front. And then likewise for CYP2C19, so you can see that these patients that are really benefiting from these tests. And it's not that simple. So challenges to the current system. We've talked about the paper referrals. You know, we really do need to move to electronic ordering. The pace of referral, like I said, from the centres, transport arrangements, all matter. This is an end-to-end pathway, and we're just a small component of it. So we need to work on that. Obviously, I've showed you an assay that's quite automated, but it could be more. The high volume does require further automation. And we talked, I know Ron mentioned about adding variants, and that's really difficult as well. You might use a CE marked assay. You can't just add variants. You've got to validate the test again. You can't, you know, so actually knowing the variants from the start that we need to have the whole picture to design an assay is what the lab absolutely needs. I mentioned the PDF reports. I'll come on to the informatics side of it, because the integration, we've talked a lot today about the patient having that information, whether it be in the NHS app. You know, if it's the EPRs don't speak to the GP record, the GP record populates the NHS app now, but if it's secondary care where these tests are ordered, it doesn't go in. So, you know, in a lot of the upload, I know from the Christie, for instance, you know, we email those results back and they manually upload from biochemistry into biochemo. You know, it's not an automatic thing. And I said before, delays in pathway. But the other big thing is the cost. So we know there's a tariff price for this on the National Test Directory, and you know we need to come in. Reagents are really expensive. We're seeing year-on-year increases, and to come in under that tariff price is also a real challenge. Yeah, and this was one of the clinicians actually in the pilot, and Vidal know this, is if you get rid of the paper form, it might be workable, maybe. You know, because those things really help people, and it's that wraparound infrastructure that needs to be in place if we're going to scale. So the second part of my talk, I just want to look forward at the forward strategy. And Sue mentioned before, that's the aim. So by 28, 29, we want to see, and the anticipation is that we'll be delivering 2 million tests, genomic tests within the NHS. And a predominant amount of them is perceived to be going to be pharmacogenomic assays. So what do we test? So I think there's this question at the moment, we're doing this little bits, you know, it's quite high volume of reactive tests, as in those in the lab. And this talk of adding new variants to those, I know I've spoken to Munir about some of those as well. But that adds a complexity to the lab, because you can't just make that change. And then we've spoken to the national team recently about these new targets. Is there a tipping point for this, that we're just adding individual reactive tests for single genes? And at next point, should we not just be doing a panel? Because when you add so many on, wouldn't that be a better, more efficient way of dealing with it? So that's in the reactive setting. And what about preemptive? When are we going to switch to that? You know, because then you can do a panel up front. Are we testing everyone in A&E? Testing everyone in hospital? Are we going to test certain age groups of people? We're already adding these targets that we know of and we need to do to our exome, but when do we report them? Can they be acted on? Are they going to be in a separate box? What does that look like? We've talked about whole genome sequencing. Yeah, it's all doable. And I know Ron said, you know, you might get incidental findings, you might not, you've viewed these, but we can tailor the bioinformatic pipeline to just home in on the ones that we really want to assay. And we've also got the next generation study in England as well, and should we be putting those pharmacogenomic targets on that now? So we're building it up from bottom and coming down from top and adding it and keeping the reactive stuff going. So it's like a multifaceted model, and you can see it's actually quite carnage for a laboratory who's trying to build a strategy. So it's not that simple, the laboratory side isn't. And then Ron touched on also, you know, how do we test? There's a lot of variants here, and not one workflow fits all of them. And that's the thing, and I think Viv said before, keep it simple. And that's what we want to do in a lab, because that makes it fast and that makes it efficient. So how do we keep it simple? when there's so many different variants. So you've got your arrays. We're using the LAMP technology, LACAR. You know, it's CE marked. We've got Thermo Fisher, who basically have custom assays that we can customise or off the shelf. We're working with APIS at the moment to look at multiplexing different things. We've got our Regina platform that we deliver the progress study on with the Network of Excellence. But again, it's not that scalable, and it's quite cumbersome in its analysis. And then obviously we've got the next generation sequencing. And at what point do you tip that threshold that you go, actually, we should just be sequencing, and we should be doing it in a preemptive setting. And so I think from where I sit, it's going to be phased. I think we will keep adding the reactive. I personally think we should be doing a small panel for those reactive tests now, and then planning for the preemptive and where do we go. But from the lab, and I think I've made this very clear, I don't want to extract. I don't want to store all this DNA. I want as simple as possible workflow. And like I think I've articulated, not one workflow is going to meet, so it might be one or two, but we just need to get to that. One of the big things we've been working on in the Northwest, mostly focused on LAMP at the moment, if I'm honest, is an automation business case, working with a couple of companies to scope out how could we do this in a really automated setting, using robotic arms with our existing instrumentation to just automate the process. And we've got some figures. We asked companies to model if we needed to get to 300,000 tests. What does that look like in terms of staff? And if they said, if we did that over 7 years, in 7 years we'd need like 7 whole-time equivalents just in the laboratory. But if we used automation, we only need 1.5. The space is a massive issue. Space in the NHS is at a premium. You can't just layer on layer more and more staff onto a workflow, because that's what you need to scale. So this literally reduces your space. You can do it in your existing footprint. And yeah, so this is a business case that we're writing at the moment. That's gone to Trust Board, Finance Committee next week. And it is adaptable. We've worked with companies to say, actually, you know, we're not stuck with a LAMP workflow if we put something like this in. So also reporting, and we talked about that quite a bit today, about, you know, we've got to move away. From the GLH perspective, we've got to move away from these PDFs. It's what we've done. It's long-standing. We're good at it. But actually, it doesn't mean the need of pharmacogenomics. So I've screenshot, and I think we meant a direct-to-consumer test. That's the 23andMe. That's actually mine. So I need a lower statin dose. But they do a very simple interpretation. It's really nice. So I think we can learn from how we can represent that in apps or EPRs that makes it easier for prescribing. So I think Vid said, and you've really like sort of, pharmacogenomics only testing is only useful if it can inform prescribing. It gets to the right place to be acted upon. It's all right the lab doing these tests, but if they just sat there and nobody knows about it or no one knows how to react to them, then they're useless. So we also need to receive the test electronically, and I know the national team are working on the order comms, which I believe is not far away, some beta testing very soon, so that would be really well received. But then actually, what is our strategy about GP returns, EPRs, unified genomic record? How are they going to speak to each other? The NHS app, all these systems, we need a system alerting as well. If, you know, they're going to flag when there's a prescription change or a dose reduction. It does require new infrastructure, and that requires new investment. Part of what the Northwest are doing is looking at that integration, and again, working with the Network of Excellence to just say, how can these engines talk to each other? These are our sort of laboratory databases, and they need to be integrated as well. If we could get everything talking to each other and integrated, it becomes a lot slicker. So that's a piece of work that Scott, who's here today, and Jan, who's our informatics and bioinformatics lead, are also working on. So where do I see the next step? So internally, we've set up a pharmaco strategy steering group with the Network of Excellence. So John's on there and Vid, and we meet regularly to sort of thrash out, you know, all of this that I've described to you today, the variants, the genes, you know, what activity levels are we aiming at? That's another big thing. You know, I'm scaling year on year. I need to know, because you need to build your laboratory to be able to deliver it. The automation investment is massive, and I know the national team have got the spending review in about that, so we're really hopeful that having a business case that's tracking ahead of that, you know, may see that we can get that into place. test reimbursement tariff I talked about. What does that look like if we start doing a small panel? Can we afford it? Can I come in under that price? Order comms, like I said, electronic reporting integration is absolutely critical to getting these results back to patients in the right format. And I've spoke a lot about the challenges, but I do think where we are, and we've done very well in the NHS as we built the genomics, and Ron said today there's a lot of positivity around it, is we've got a real opportunity to work together with the national team, with the networks of excellence, to really build a pharmacogenomic testing service for the future. And I'm sure that we all agree that's what we're all here today. And there's such positivity, and we can learn certainly from the Netherlands, and your panels and things like that, that I just think that, you know, it's for us to shape. So thank you.
Thanks very much, Emma, for covering a great range of challenges. A question or two from the audience for Emma before we finish? Yes, here?
Hi, I'm Jackie O'Brien. I'm working on this CPGX project, but also chair the Industry Pharmacogenomics Network. I have a question for Ron, which I can come back to offline afterwards, but about the harmonisation of bringing labs together and having those conversations. But for the purpose of this presentation, I noticed you've got a huge number of work packages. You've got a huge amount of work to do. We have a very positive medical device industry for pharmacogenomics in the UK who really, really want to work with the NHS and align with the NHS and support you find some of the solutions that you're looking for. How do we engage more closely with you, and how do we ensure that we can be part of the conversations when you're making those decisions?
Yeah, so absolutely, we're happy to work with people. So if you just contact myself or Vicky, and we can bring you into some of those conversations that we've got within that steering group that we've established. There's different branches of that, you know, we're talking to different companies about assay design, we're working with them, perhaps being beta testing sites. So yeah, please just get in touch and we'll have that conversation.
Thank you.
Yeah, I would suspect you probably also need to talk to Sue.
Yeah.
If you're not already.
Well, Debbie's got a hand up
Yes.
from the national team.
Just in the absence of Sue, if I can just come in, there is an absolute intention to work with industry, and Sue did mention right at the beginning in her opening speech there was a collaboration between ABPI, MRHA, NICE, etc., and bringing those in. That's quite burgeoning at the moment, but I'm sure they'll be very welcome to have this conversation about pharmacogenomics at a national level and bring you in.
Okay, final question from Ron, please.
Sorry to make you run. Okay. Yeah, just I was intrigued by the positive point that you pointed out with the technique that you're using, the lab.
Yeah.
Because you do not have to store DNA. So I can see that it's an advantage, but from my perspective, I was always a little bit, perhaps I'm too afraid, but I'm so afraid that I will do the genotyping now, and then 10 years later, another lab will do the genotyping and will come up with another result.
Yeah.
And then the question is, did I make a mistake at the time? Or did the new lab make a mistake? Or is technology further? So I'm always very keen to go back to the DNA, which I had, that I could at least with the new technologies that are there confirm, hopefully, that I was right in the beginning. So perhaps I'm a little bit too afraid of liability there, but that could be a positive thing of storing samples there as well.
Yeah.
So how do you reflect on that?
No, you're absolutely right. But what I will say is we've had a bit of an incident recently, and even though we've got the DNA, we can't replicate the test because, and it's not in pharmacogenomics, by the way, because I haven't got the primers anymore, and I can't replicate because I haven't got the PCR machines. So you're right, it does mean that we can't go back to the original sample, but sometimes you just can't replicate it anyway, you know, because you're 20 years down the line. So we did take that decision. We spoke with all the labs about it, and it is only the pharmacogenomics that we do it for. And I think a lot of it was because, as well, there's no predictive testing for it, so there's no family member testing, so we would never need it as a positive. So that came into the decision making too.
Right, wonderful. Thank you very much. I must say that it's good that unlike Ron, I've got more than one person in the audience still, so you've done very well on a Friday afternoon. But the level of engagement all day has been fantastic. There's been great energy. I think it's been really nice to hear different perspectives, to have sort of combination of talks, of panel discussion that we had, and then the workshops. I think that's been really nice to sort of have different ways of exchanging ideas, listening, understanding and learning. And, you know, just now I was sort of sitting looking at the panel and thinking, gosh, you all come from different sort of health professional or professional backgrounds. You've all got loads of different experience and loads of skills, and you're sharing and talking about them. And that's something that I think is really wonderful about the whole network that we've really seen develop over the last couple of years. And as we heard earlier, there's going to be more network. So that's really great. So, you know, the fact that Sue, in her talk earlier, gave the commitment to this network going forward. So, as I said, we really are keen for you to come forward with your ideas about things that you think we should be addressing, things that we've already discovered, learned, that we can make better, and some of it's about scale. And just, you know, as Ron said, just doing it, you know, just getting up and doing it. And some of that's right, because it's only when there's real elements about thinking about things, designing stuff, working hard to craft something, to do it and deliver it as well as you can. But ultimately, you've got to do some stuff as well, because then you iterate back and you learn from that, and then you keep improving and you keep trying to make things better. So it's really important to thank the people who have made today possible. Obviously, all the speakers and the people who facilitated the groups and contributed, the people like Barbara, Alison, Lisa, Jack, and the team with Emma in Newcastle, who have made us so welcome. It's a great venue. The whole setup has been fantastic. And then also, you know, just all the logistics about getting the information out to us and all of that sort of stuff has been fantastic. Please do give us your feedback. We're very keen to hear what you thought of the day, things that you'd like to see more of or whatever, and register for the next meeting in November, 13th of November. We're pulling together the programme now. It's still at a very embryonic stage, so if you've got ideas, let us know, because we've got some things that we want to do. There'll be an update on the CERSI programme that you heard about earlier from that Meneers leading in Liverpool, which will be great, and a couple of other ideas that we've got as well, but there's still room in that programme as well. So have a safe trip home. I see the sun shining, hopefully not just in Newcastle, but in the rest of the country. Have a safe trip home and enjoy your weekend and carry on pushing forward pharmacogenomics. Thanks so much.